Hi there, my name is Swarup Swaminathan, and I'm a glaucoma specialist and clinician scientist at the Bascom Palmer Eye Institute at the University of Miami Miller School of Medicine. As a clinician scientist, I spend my time seeing patients in clinic, completing surgery in the operating room, and conducting clinical research in the area of glaucoma. Glaucoma is the leading cause of blindness worldwide, affecting over 80 to 90 million individuals. It is one of the most common causes of irreversible blindness in the world, and here at home, it disproportionately affects the African American and Latinx communities, whose members are 5 times more likely to develop the disease. Over 3 million Americans suffer from glaucoma, and almost half of them do not even know about it. Age, family history, and elevated eye pressure are key risk factors in developing glaucoma. Notably, elevated eye pressure is the only modifiable risk factor. That is, it is the only risk factor that we as ophthalmologists can help change in order to reduce the probability that a patient would lose vision from their disease. As the US population continues to grow older and older, more and more Americans are going to seek care for glaucoma. The economic burden of caring for low vision or blind individuals is immense, with some reports indicating expenditures of almost $27,000 per year per individual. And needless to say, the psycho-emotional component of blindness is enormous. Now, glaucoma is a disease that affects the optic nerve, or the cable that connects the eye to the brain. Unfortunately, damage to this optic nerve is permanent when it occurs. Humans are unable to regenerate this tissue when it's damaged. Fortunately, glaucoma progression can be slowed using medication, laser, or surgical therapy to lower the eye pressure. Of course, timely interventions are essential in this process. In glaucoma, cells within the retina die off. The retina is a collection of millions upon millions of cells in the back portion of the eye that help us see and help us appreciate colors and contrast. When these cells die off, their fibers also degenerate, and that subsequently leads to the thinning of this cable, or the optic nerve. The thinning of these fibers in the retinal nerve fiber layer, or RNFL, can be studied using special photography of the retina known as optical coherence tomography, or OCT for short. OCT can help the clinician identify thinning of the RNFL in glaucoma patients. Now, as more of the structural damage occurs and is documented by OCT testing, functional vision loss begins to occur. And this is tested using perimetry, or visual field testing. Functional vision loss manifests as peripheral vision defects on visual field testing initially. Eventually, and if untreated, glaucoma slowly works its way towards the center, culminating in total blindness. Correlating changes in structure and function is essential when treating glaucoma in order to provide an accurate assessment of the nature of a patient's degree and their level of visual disability. Predicting how rapidly they may worsen at their current level of disease has been challenging, and up to this time has primarily relied on the use of basic statistics. My work focuses on trying to change this paradigm. My focus is to develop large structure-function databases here at the Bascom Palmer Eye Institute in order to improve our ability to risk stratify glaucoma patients. By having access to large databases and by using higher order statistical methodologies such as artificial intelligence, we, as ophthalmologists, can refine our predictive abilities. We can then differentiate between stable patients and high-risk patients, thereby minimizing visits for those who are stable or low risk, while ensuring appropriate attention is given to those who are at high risk for vision loss from glaucoma. My previous research has demonstrated the importance of using both structural and functional testing when assessing for vision loss. This work was a collaboration between myself and colleagues at the Duke Eye Center, where I completed my fellowship training in glaucoma. While thinning of the RNFL layer is known to increase the overall risk of subsequent vision loss, the association between the rate of RNFL thinning and the rate of subsequent vision loss has not been clearly demonstrated. Does a patient who has rapid tissue loss on their OCT also have subsequent rapid loss of their peripheral vision on visual field testing? Do these rates correspond? By evaluating a large database of over 1,100 eyes of 800 glaucoma patients, We demonstrated that the rate of initial RNFL thinning due to glaucoma is correlated with the rate of concurrent or subsequent visual field loss. Rapid structural loss over the initial period, which was 3 years, led to faster visual field loss over 6 years. Now, our work shows that rapid changes initially noted on structural glaucoma testing should warrant an increase in a patient's treatment, even before visual field changes are noted. Identifying those patients with fast rates of structural change can help prevent irreversible visual field loss at a later date. Conducting such research with large databases and with refined statistical methodologies will improve our ability to identify high-risk glaucoma patients. And I look forward to continuing further studies here at the Bascom Palmer Eye Institute. Thank you very much for your time.